Your doctor looks at your test results, smiles, and says your cholesterol is normal. You feel relieved. You've been worried about heart disease, but now you can relax, right? Your numbers are good. You're in the clear, except you're not. Because what almost nobody tells you is that normal cholesterol doesn't always mean low risk. In fact, half of all people who have heart attacks have completely normal cholesterol levels. Let that sink in for a moment. Half. So if cholesterol isn't the whole story, what is? What are doctors missing? What should you actually be paying attention to? And why are so many people with perfect cholesterol numbers still having heart attacks and strokes? Let me start by explaining what's actually happening in your arteries when heart disease develops. Most people think it's simple. Cholesterol builds up in your arteries like sludge in a pipe. The more cholesterol you have, the more buildup, the more blockage. Lower your cholesterol, clear the pipes, problem solved. But that's not how it actually works. That's a massive oversimplification that's led to decades of misguided treatment. Here's the truth. Heart disease starts with damage to the lining of your arteries. This lining is called the endothelium, and it's a single layer of cells that's incredibly delicate. When this lining gets damaged, your body tries to repair it. It sends cholesterol to the damaged area as part of the repair process. Cholesterol is actually there to help. It's not the criminal. It's the emergency responder showing up at the scene of the crime. But what caused the damage in the first place? That's the real question. And the answer is inflammation. Chronic inflammation damages your arterial walls. It can be caused by high blood sugar, oxidative stress, high blood pressure, toxins, smoking, chronic stress, poor sleep, infections, and yes, even some of the foods you eat. When inflammation damages your endothelium repeatedly over years, your arteries try to repair themselves over and over, and that's when plaque forms. Now here's what's critical to understand. The cholesterol that shows up in a standard cholesterol test, your total cholesterol and even your LDL, doesn't tell you anything about inflammation. It doesn't tell you if your arteries are damaged. It doesn't tell you if you have plaque. And it certainly doesn't tell you if that plaque is stable or if it's about to rupture and cause a heart attack. Let me explain something about plaque that most people don't know. Not all plaque is the same. You can have what's called stable plaque. This is plaque that's been there for years, calcified, hard, not going anywhere. It might narrow your artery a bit, but it's not immediately dangerous. Then you have unstable plaque, sometimes called vulnerable plaque or soft plaque. This plaque has a thin cap and a lipid-rich core. It's inflamed, it's angry, and it can rupture suddenly, causing a blood clot that completely blocks your artery. That's what causes most heart attacks. And here's the kicker. You can have normal cholesterol levels and be full of this unstable, dangerous plaque. Because the standard cholesterol test isn't measuring what matters, it's measuring the wrong thing. So what should you be looking at instead? First, you need to understand that not all LDL cholesterol is created equal. LDL stands for low-density lipoprotein, but that's actually a category, not a single thing. There are different types of LDL particles. Some are large and fluffy, like beach balls. These large particles are mostly harmless. They're too big to penetrate your arterial wall and cause problems. Then there are small, dense LDL particles, like golf balls. These small particles can easily slip between the cells of your arterial lining, get trapped there, become oxidized, and trigger inflammation and plaque formation. Your standard cholesterol test doesn't distinguish between these. It just tells you total LDL. You could have a normal LDL number, but have mostly small, dense particles, which puts you at high risk. Or you could have a slightly elevated LDL number, but have mostly large, fluffy particles, which means your risk is actually low. The number alone tells you almost nothing. There's a test called an NMR lipoprofile, or a cardio IQ test that measures your LDL particle number and size. This is far more predictive of heart disease risk than standard cholesterol numbers. But most doctors don't order it. They stick with the basic panel, because that's what insurance covers, and that's what they've always done. Let me tell you about another marker that's incredibly important but rarely checked. It's called LPA, lipoprotein(a). This is a genetic variant of LDL cholesterol that's extremely inflammatory and promotes blood clotting. About 20% of the population has elevated LPA, and it dramatically increases heart attack and stroke risk. You can eat perfectly, exercise daily, have normal cholesterol, and still be at very high risk if you have elevated LPA. The scary part? Most people have no idea what their LPA level is because doctors rarely test for it. It's genetic, so if it's high, it's been high your whole life. And it doesn't respond to diet or statins. You could be doing everything right and still be walking around with a ticking time bomb in your arteries, completely unaware. Now let's talk about inflammation markers. Remember, inflammation is what's actually causing the damage. There's a test called high-sensitivity C-reactive protein, or HSCRP. This measures inflammation in your body. Studies have shown that HSCRP is a better predictor of heart attack risk than LDL cholesterol. You can have sky-high cholesterol and low inflammation, which means your risk is probably lower than someone with normal cholesterol, but high inflammation. But again, most doctors don't routinely check this. They focus on cholesterol because that's what we've been taught for 50 years. Lower the cholesterol, prescribe a statin, case closed. Meanwhile, the inflammation that's actually driving the disease goes completely ignored. There's another marker called homocysteine. This is an amino acid that, when elevated, damages your arterial walls and promotes blood clotting. High homocysteine is strongly associated with increased heart disease risk, but it's not part of standard testing. It's often elevated in people who are deficient in B vitamins, particularly B6, B12, and folate. A simple vitamin deficiency could be destroying your arteries, and you'd never know it from a standard cholesterol test. Let me tell you about something else that standard cholesterol tests miss entirely. It's your triglyceride to HDL ratio. This is one of the best markers of insulin resistance and metabolic health. You take your triglycerides and divide by your HDL. If that ratio is higher than 2, you likely have insulin resistance, even if your doctor hasn't diagnosed you with it. And insulin resistance is one of the biggest drivers of heart disease. Why? Because when you're insulin resistant, your body is constantly producing high levels of insulin to deal with blood sugar. High insulin causes inflammation. It tells your liver to produce more of those small, dense LDL particles. It lowers your HDL, the protective cholesterol. It raises your triglycerides. It promotes fat storage around your organs. It raises your blood pressure. Insulin resistance is like throwing gasoline on the fire of heart disease. And you can have completely normal total cholesterol and LDL, but have a terrible triglyceride to HDL ratio, which means your metabolic health is a disaster and your heart disease risk is through the roof. But if your doctor only looks at total cholesterol and LDL, they'll tell you everything's fine. Here's something else that's critical. Your fasting insulin level. Not your blood sugar, your insulin. Most doctors only check blood sugar and hemoglobin A1C to assess diabetes risk. But by the time those numbers are elevated, you've already had insulin resistance for years, maybe decades. Your pancreas has been pumping out more and more insulin to keep your blood sugar normal. And all that excess insulin has been silently damaging your arteries. A fasting insulin test can detect insulin resistance years before you develop diabetes. It gives you a chance to intervene early, to change your diet and lifestyle before the damage becomes irreversible. But most doctors don't check it. They wait until you're diabetic, and by then, significant arterial damage has already occurred. Let me tell you about something called coronary artery calcium score, or CAC score. This is a CT scan that measures how much calcified plaque you have in your coronary arteries. It's like looking directly at your arteries and seeing what's there. A score of 0 means no detectable plaque. A score over 100 means significant plaque. Over 400 means very high risk. This test is incredibly valuable because it tells you what's actually happening in your arteries, not what we're guessing might happen based on cholesterol numbers. You could have normal cholesterol, but a high calcium score, which means you need aggressive treatment. Or you could have high cholesterol, but a 0 calcium score, which means maybe you don't need medication after all. But here's the problem. Insurance often doesn't cover this test. It costs a few $100s out of pocket. And many cardiologists don't recommend it routinely, even though it provides far more useful information than a standard cholesterol panel. Now let's talk about something controversial: the role of statins. Statins are the most prescribed drugs in the world for lowering cholesterol. And yes, they do lower cholesterol effectively. But do they actually prevent heart attacks in people who haven't already had one? The data is far less convincing than you'd think. For people who've already had a heart attack, statins provide a clear benefit. They reduce the risk of another event. But for primary prevention, preventing a first heart attack in people with elevated cholesterol but no history of heart disease, the benefit is much smaller. You'd need to treat dozens or even hundreds of people with statins for years to prevent one heart attack. And statins come with side effects: muscle pain, fatigue, cognitive issues, increased diabetes risk, and nutrient depletion, particularly of coenzyme Q10. What if the reason statins show some benefit isn't because they lower cholesterol, but because they have anti-inflammatory effects? Statins do reduce inflammation, reduce CRP levels. Maybe that's the mechanism that's helping, not the cholesterol lowering. If that's true, then we should be focusing on reducing inflammation through diet, lifestyle, and targeted supplements, not just blindly lowering cholesterol with drugs. Here's what's really frustrating. The medical establishment has been so focused on cholesterol for so long that they've ignored or downplayed other risk factors that are often more important. Things like chronic stress, which raises cortisol and blood pressure and promotes inflammation. Poor sleep, which disrupts every system in your body. Lack of physical activity. Social isolation and loneliness, which have been shown to increase heart disease risk as much as smoking. Chronic infections and imbalanced gut microbiome. All of these things contribute to heart disease, often more significantly than your cholesterol level. But when was the last time your doctor spent time talking to you about stress management or sleep quality during your annual physical? They check your cholesterol, maybe your blood pressure, and send you on your way. If your cholesterol is high, they write a prescription. If it's normal, they tell you you're fine. Case closed. But it's not closed. Because you could be doing everything right according to conventional wisdom, taking your statin, eating your whole grains, avoiding saturated fat, and still be marching toward a heart attack because the real drivers of your disease are being completely ignored. Let me tell you what you should actually be doing. First, demand better testing. Ask your doctor for an NMR lipoprofile or cardio IQ to measure your LDL particle number and size. Ask for LPA. Ask for HSCRP to measure inflammation. Ask for homocysteine. Ask for fasting insulin, not just fasting glucose. Ask about getting a coronary artery calcium scan, especially if you're over 50 or have risk factors. Second, focus on reducing inflammation. This is the key to preventing heart disease. How do you reduce inflammation? You eliminate or reduce sugar and refined carbohydrates. You eat whole, unprocessed foods. You include plenty of omega-3 fats from fatty fish or supplements. You eat lots of colorful vegetables rich in antioxidants. You manage your stress through meditation, yoga, time in nature, whatever works for you. You prioritize sleep. You move your body regularly. You maintain healthy relationships and social connections. Third, understand that saturated fat is not the enemy we've been told it is. The idea that saturated fat raises cholesterol and causes heart disease is based on weak science and has been thoroughly debunked. What matters is the quality of the fat and what you're eating it with. Butter from grass-fed cows, coconut oil, fatty cuts of pasture-raised meat, these are not going to give you heart disease, especially if you're not eating them with sugar and refined carbs. Fourth, consider that lowering your cholesterol too much might actually be harmful. Cholesterol is essential. Your brain needs it. Your hormones are made from it. Every cell in your body uses it. Some studies suggest that very low cholesterol is associated with increased risk of cancer, depression, and death from other causes. There's a sweet spot, and it's probably higher than mainstream medicine wants to admit. Fifth, if you're taking a statin, make sure you're supplementing with coenzyme Q10. Statins deplete CoQ10, which is critical for energy production in your cells, especially your heart muscle. This depletion is probably why many people on statins experience muscle pain and fatigue. Taking 100 to 200 milligrams of CoQ10 daily can help offset this. Here's the bottom line. Normal cholesterol doesn't mean you're safe from heart disease, and high cholesterol doesn't necessarily mean you're in danger. Heart disease is complex. It's driven by inflammation, insulin resistance, oxidative stress, endothelial dysfunction, and yes, cholesterol particles of certain types. But the standard cholesterol test only gives you a tiny piece of the picture, and it's often not even the most important piece. You need to be your own advocate. You need to ask for better testing. You need to focus on the things that actually matter, inflammation and metabolic health, not just a number on a piece of paper. And you need to understand that preventing heart disease is about so much more than lowering cholesterol. It's about creating an internal environment where disease can't take hold. An environment with low inflammation, stable blood sugar, healthy stress levels, good sleep, strong relationships, and joyful movement. Your heart deserves better than a one-size-fits-all approach based on outdated science. It deserves the full picture, and so do you.